Hello, I'm Dr. Sara Hurvitz from the University of California, Los Angeles, talking to you today about the ideal partner to HER2-directed therapies. Now, I have to admit, when I was first asked to give this talk, I initially thought this would be an easy lecture to give, but as I thought more about it, it actually isn't clear that there is solid evidence to tell us the ideal partner for a HER2 positive, hormone receptor positive breast cancer. And so before answering this question directly, I thought I would break this talk down into some fundamental components. And the fundamental questions I'll address before getting into the ideal partner are shown here. The first of these will be, how often does this occur? How often is the hormone receptor co-expressed with HER2? And when looking at clinical trials, actually, that enrolled patients with only HER2 positive breast cancer, roughly half to 2/3 of patients that have HER2 positive breast cancer have hormone receptor co-expression. But if you're looking at all breast cancer subtypes, this subtype comprises around 10% of breast cancer. Now, crosstalk between these two pathways isn't the focus of my particular talk in this session. However, there is strong preclinical evidence that receptor crosstalk does occur, which provides sound rationale for exploring studies that use therapies that target multiple pathways when both receptors are expressed. Another fundamental question is whether or not disease outcomes are inherently different in patients with hormone receptor co-expression. In the neoadjuvant setting, we know that tumors that have co-expression of hormone receptor and HER2 have a lower chance of complete response to chemotherapy, either alone or in combination with trastuzumab, than those HER2 positive breast cancers without hormone receptor co-expression. This has been consistently shown in more modern neoadjuvant studies shown here that we're also incorporating dual HER2 targeted therapy. So you can see here that the chance of a path CR in ER positive HER2 positive breast cancer is consistently lower than in patients who have ER negative HER2 positive breast cancer. But does that really mean that hormone receptor positive tumors will do worse than hormone receptor negative HER2 positive breast cancers in the long term? And in fact, the answer to that is no, actually. Hormone receptor positive tumors that are HER2 positive inherently seem to do better long term in the absence of HER2 targeted therapy. Shown here are long-term outcomes from the N9831B31 studies based on hormone receptor status, with the blue curve representing patients with hormone receptor positive tumors treated with chemo alone. They do better than the red curve, which is hormone receptor negative HER2 positive tumors treated with chemo alone. Similarly, long-term data from HERA shown here seems to indicate that those with hormone receptor negative tumors have a worse disease-free survival compared with those with hormone receptor positive tumor when treated with chemotherapy alone. Even data from the APT clinical trial of low-risk early-stage HER2 positive breast cancer seem to suggest that those with hormone receptor negative HER2 positive disease may do worse long-term after treatment with paclitaxel trastuzumab, although admittedly the numbers are quite small here. And data from 5 large trials in the curative setting shown here also indicate that hormone receptor positive disease tends to do better long-term than hormone receptor negative disease. But what about outcomes in metastatic disease? Well, a study in British Columbia over a decade ago now followed patients diagnosed with early breast cancer from 1986 to 92 and evaluated the rate of metastatic recurrences by disease subtype. With over 3,700 patients and a median follow-up of almost 15 years, the HER2 positive subtype had high rates of relapse in the absence of trastuzumab, regardless of hormone receptor status. And once metastatic disease was diagnosed, the median survival was lower for hormone receptor negative compared to hormone receptor positive. Interestingly, the hormone receptor negative subtype had a higher rate of brain and lung metastases and a lower rate of bone metastases than hormone receptor positive. So the disease biology does appear to differ slightly inherently when hormone receptors are co-expressed with HER2. Now, the next question is whether benefits of HER2 targeted therapy depend on hormone receptor status. And if you look at that 10-year results of the joint analysis I showed you a few minutes ago, again, it's clear that both the hormone receptor positive and hormone receptor negative subtypes significantly benefit from trastuzumab. And in fact, the outcomes appear to come a bit closer together. Similarly, long-term data from HERA indicates that both hormone receptor positive and hormone receptor negative disease significantly benefit from the use of a year of trastuzumab. And since the approval of adjuvant trastuzumab, we've had the approval of 3 other agents in the curative setting, pertuzumab, T-DM1, and neratinib, begging the question, does the benefit of these additional agents depend on hormone receptor status? So let's look at those data here. Data from the affinity shown here show that the use of pertuzumab for a year in addition to trastuzumab does appear to benefit patients regardless of hormone receptor status. And data from Catherine shown here with the use of adjuvant T-DM1 in patients with residual disease after standard neoadjuvant therapy shows that T-DM1 is beneficial regardless of hormone receptor status, as seen in this forest plot here. However, the data from Extenet tell a different story. Here, the use of a potent pan-HER inhibitor, neratinib, benefits only those patients with hormone receptor positive disease. This finding may be explained by the fact that neratinib targets HER1, 2, and 4, thus mitigating receptor crosstalk with the hormone receptor pathway. Patients with hormone receptor positive disease received in this clinical trial concurrent adjuvant endocrine therapy. And so we're receiving potent inhibition of the hormone pathway as well as the HER2 pathway, which may be responsible for the development of resistance to hormonally targeted and HER2 targeted therapies. Now, what about the benefits from new HER2 targeted therapies such as pertuzumab, tucatinib, neratinib, and T-DXd in the metastatic setting? Are the benefits of novel agents dependent on hormone receptor status? So showing you first here the Cleopatra data, you can see that overall survival is improved significantly for both hormone receptor positive and hormone receptor negative disease by adding pertuzumab to docetaxel and trastuzumab. Similarly, T-DM1 benefits patients regardless of hormone receptor status in the phase 3 Teresa clinical trial. And data from the HER2 CLIMB study indicate the benefit of adding tucatinib, a HER2 selective TKI, to chemo and trastuzumab is regardless of the hormone receptor status. And recent data relating to T-DXd, a novel antibody drug conjugate that targets HER2, compared head-to-head against T-DM1 in the DESTINY-Breast03 clinical trial, indicates that the substantial progression-free survival benefits with T-DXd are observed both in the hormone receptor positive and negative studies, cohorts. And so another fundamental question now is whether adding HER2 targeted therapy to endocrine therapy is beneficial. Data from the TANDEM and EGF 3008 clinical trials are shown here on this slide, and they do indicate that the addition of HER2 targeted therapy to endocrine therapy improves outcomes compared to endocrine therapy alone, albeit modestly. But keep in mind the very poor objective response rates and progression-free survival associated with single agent endocrine therapy shown in the black here alone. This brings me to the latter part of my talk, which is aimed to address what the ideal partner is for hormone receptor positive, HER2 positive breast cancer. And the first question is whether adding endocrine therapy to HER2 targeted therapy is beneficial. You will recognize this table I just showed you a few moments ago from the TANDEM and EGF 3008 trials, in which endocrine therapy alone or in combination with HER2 targeted therapy was addressed. What was clearly lacking from these two clinical trials was an arm with single agent HER2 targeted therapy to isolate the benefits, if any, imparted by endocrine therapy alone. And to try to address this, I've pulled outcomes from studies looking at single agent HER2 targeted therapy in green italics. Comparing those data to the endocrine therapy plus HER2 targeted therapy data, it does not appear that endocrine therapy is actually adding much benefit. Now, of course, this isn't a fair comparison. It's a cross-trial comparison. And the lapatinib single agent data outcomes come from those with both hormone receptor positive and hormone receptor negative disease, making this comparison even a little bit less fair. But I just wanted to use this to illustrate the point that it's not really clear how much endocrine therapy is benefiting patients when added to HER2 targeted therapy. However, we do have a clinical trial, the NSABP B52 clinical trial, which did compare HER2 targeted therapy and chemo with or without endocrine therapy to try and isolate whether endocrine therapy is benefiting patients. This is a phase 3 neoadjuvant trial in which patients with hormone receptor positive, HER2 positive early breast cancer receive standard chemo plus trastuzumab and pertuzumab with or without endocrine therapy. The pathologic complete response rate from this trial was no better by adding endocrine therapy, regardless of the menopausal status. Another study, the ADAPT clinical trial, also a neoadjuvant study, aimed to assess the benefits of adding endocrine therapy to HER2 targeted therapy in hormone receptor co-expressing breast cancers by comparing TDM1 alone or with endocrine therapy to trastuzumab plus endocrine therapy. Interestingly, and similar to the NSABP B52 trial, the addition of endocrine therapy to TDM1 did not improve the path-CR rate. Now, neither of these studies have presented long-term outcomes in terms of invasive disease-free survival, but that short surrogate marker of path-CR doesn't seem to indicate any benefit by adding endocrine therapy. So to date, we really do not have clear evidence that adding endocrine therapy to HER2 targeted therapy improves outcomes. But another question is whether dual HER2 targeted therapy is better than mono HER2 targeted therapy when combined with endocrine therapy in ER positive, HER2 positive breast cancer. Here is a summary of some neoadjuvant trials where patients receive dual HER2 targeted therapy plus endocrine therapy with their corresponding path-CR rates. In these trials, chemo was not used, and the path-CR rates ranged from 18 to 27%, which isn't bad, but not as high as we get with chemotherapy. In the metastatic setting, the alternative trial evaluated endocrine therapy combined with HER2 targeted monotherapy or dual HER2 targeted therapy with lapatinib trastuzumab. The progression-free survival was longest with dual HER2 targeted therapy, and the use of the TKI lapatinib trended toward a better PFS compared to the use of trastuzumab mono HER2 targeted therapy. Again, this may relate to the fact that lapatinib targets EGFR as well, inhibiting receptor crosstalk with hormone pathways. But keep in mind, this study does not address whether the addition of endocrine therapy is benefiting patients, whether it's necessary in addition to the dual HER2 targeted therapy. Another trial, the PERTAIN trial, also evaluated dual HER2 targeted therapy, this time with pertuzumab and trastuzumab versus trastuzumab monotherapy for metastatic disease. All patients, again, received endocrine therapy, and patients could receive induction chemotherapy per physician choice. They weren't randomized to that. Similar to alternative, the use of dual HER2 targeted therapy improved progression-free survival, and the benefits of this approach were even more pronounced in those who did not receive induction chemo. The median overall survival for HP was around 5 years, which is similar to that reported in the Cleopatra trial, where endocrine therapy was not used. It's important to note that this study, again, does not address the relative benefits imparted by the inclusion of endocrine therapy, since all patients received endocrine therapy in this study. Moreover, it does not address whether outcomes are similar for patients who omit or receive induction chemotherapy, because patients were not randomized to chemotherapy treatment. I've summarized here the progression-free survival for patients with hormone receptor positive, HER2 positive breast cancer on this graph. Again, dual HER2 targeted therapy is associated with longer progression-free survival, but how much or whether endocrine therapy is adding to this benefit has never been established to my knowledge. On to the next question. Is chemotherapy needed in hormone receptor positive, HER2 positive breast cancer? Can it be omitted? So back to the ADAPT trial, the neoadjuvant study I showed you from the West German group. In this study, the path CR rate was highest with TDM1 compared to trastuzumab endocrine therapy, underscoring the benefits of chemotherapy in HER2 positive disease, even hormone receptor positive, HER2 positive. And again, the addition of endocrine therapy did not improve path CR. Another neoadjuvant clinical trial, the triple positive, evaluated HP plus endocrine therapy versus HP plus paclitaxel and showed a marked improvement in pathologic complete response with the addition of chemotherapy to HER2 targeted therapy. In the metastatic setting, we have the Monarch clinical trial, which compared chemotherapy to the CDK4/6 inhibitor abemaciclib in HER2 positive, hormone receptor positive breast cancer. In this study, chemotherapy plus trastuzumab was compared to endocrine therapy, trastuzumab abema, or trastuzumab abema. In this study, the triplet approach yielded not only a significantly improved PFS, but also a more than doubling in the objective response rate compared to chemo. This is the only example I could find where a non-chemo approach beat a chemo approach in HER2 positive disease. It's interesting that fulvestrant appears to be important as the doublet with the CDK4/6 inhibitor, and trastuzumab did not do as well. Again, this study was not able to establish the relative benefits of abemaciclib, however, as there was no fulvestrant trastuzumab arm. However, the ongoing phase 3 PATINA trial will isolate the effects of a CDK4/6 inhibitor in this setting by evaluating whether palbociclib adds benefit to HER2 targeted therapy plus endocrine therapy after standard induction treatment in metastatic disease. And at ASCO this past year, the SYS-UCC02 trial results were presented. In this study, patients were randomly assigned to endocrine therapy plus trastuzumab or chemo of physician's choice plus trastuzumab for the first-line treatment of hormone receptor co-expressing breast cancer. And although this study didn't meet its endpoint of showing superiority of the chemotherapy arm, the PFS was strikingly similar for the two arms, as was the overall survival. It's interesting to note that the median overall survival, however, in this first-line study is around 36 months, which compares unfavorably to the Cleopatra trial, in which trastuzumab and pertuzumab plus chemotherapy were shown to yield a median overall survival close to 5 years. However, this study leaves some outstanding questions. Would the outcomes have differed had the study incorporated the use of pertuzumab, which is the standard of care in many parts of the world now in the frontline setting? Were the outcomes also affected by the type of chemo used? It's unclear how many patients received taxane versus capecitabine or vinorelbine in the frontline setting. And it's also unclear how many patients had taxane-resistant disease, meaning having a recurrence after the use of a taxane in the adjuvant or neoadjuvant setting. It's also unclear whether outcomes were affected by the type of endocrine therapy used, as this was not reported. And selection bias may have been important in the results of this study because clinicians may have selectively enrolled patients with less aggressive behaving disease for this clinical trial, where patients were randomly assigned to potentially receive a non-chemo arm. The study design does not allow us to gauge whether the use of initial rounds of chemo followed by endocrine therapy, for example, THP followed by HP plus endocrine therapy, is equivalent to a non-chemo approach of HP endocrine therapy without any chemotherapy being used. However, there are a few ongoing studies that may help answer these questions. The DETECT-5 study will compare chemo induction followed by maintenance HP ribociclib endocrine therapy versus a chemotherapy-free approach of HP ribociclib and endocrine therapy. This will allow us to isolate the benefits of chemo, but will not address how much benefit ribociclib is adding, as both of the treatment arms do receive ribociclib. And then the TOUCH trial will compare pathologic complete response rates with chemotherapy plus HP versus a non-chemo approach of HP endocrine therapy and palbociclib with PathCR as the primary endpoint. And then my colleague, Nick McAndrew, will be opening this clinical trial shown here, in which patients will be randomly assigned to ribociclib plus tucatinib and trastuzumab and fulvestrant compared to a standard TCHP type of approach in the hormone receptor positive, HER2 positive cohort. So is chemotherapy needed in hormone receptor positive, HER2 positive breast cancer? Maybe not. We still lack results from any prospective randomized trial comparing induction chemo and HER2 targeted therapy followed by maintenance HER2 targeted therapy and endocrine therapy versus a HER2 targeted therapy and endocrine therapy without any chemo. And the use of a CDK4/6 inhibitor may substitute for chemotherapy, but only if endocrine therapy and HER2 targeted therapy are used with it, it appears. We have some ongoing studies that will hopefully further define whether or not CDK4/6 inhibition can replace chemotherapy in patients with hormone receptor positive, HER2 positive breast cancer. So in summary, targeting HER2 remains incredibly important even when hormone receptors are co-expressed. Outcomes are better with HER2, dual HER2 targeted therapy compared to a single HER2 targeted therapy when the hormone receptor is co-expressed. It's still not entirely clear whether adding endocrine therapy to HER2 targeted therapy substantially improves outcomes in this subtype of breast cancer. And really, in my opinion, and based on the available evidence, chemotherapy does remain the standard of care in the curative and metastatic settings, since most studies indicate a better outcome than a chemo-free approach. The SYS-UCC study was a nicely designed study, a very important trial, but it may have been affected by selection bias and did not address whether induction chemo would have been associated with a better outcome long-term. And we have to keep in mind the median OS reported in that trial compares unfavorably when we do a cross-trial comparison to the Cleopatra study. That said, for some patients, a chemo-free approach may be reasonable. So we need to take into account our patient's performance status and comorbidities as we're making these treatment decisions. And it is critical that we support ongoing clinical trials that are aimed to better define how we should treat these patients with this subtype of breast cancer. Thank you so much for your attention.